The goal of this presentation is to help providers understand the key element of documentation for critical care services. It will include how we define critical care and explain the necessary reporting requirements. We will also review some clinical examples to help you translate this information into your daily practice. Critical care is delivered by a provider for a patient that has a critical illness or injury that will impact one or more vital organ systems with a high likelihood of imminent or life-threatening deterioration of the patient. It requires your direct personal management to support life or vital organ functions, and requires interventions based on your personal assessment and manipulation of the patient's condition. Critical care service can be provided in any location provided it meets the definition of critical care and all the documentation requirements. If these interventions did not take place urgently, the patient would likely have sudden, significant or life-threatening deterioration. There are many conditions that can lead to you providing critical care. CNS failure, shock, acute renal failure and respiratory failure are only a few of the conditions that can qualify for critical care services. This is not an exhaustive list. The key element when reporting critical care is your documentation. There are 3 components of critical care documentation. The first element is time. It is important to keep in mind that critical care is a time-based code. The time includes activities related to the care and treatment of one specific patient, including reviewing current test results, assessing the patient vital signs, and other time spent on a critical care unit or other clinical area caring for the patient. The second element is documentation of critical nature of the patient's condition. Your documentation should clearly indicate all the diagnosis and treatment options that you are doing or are considering when caring for the patient. It needs to support why the patient is critical and the nature of the condition. The final element is medical decision-making. In order to report critical care, your documentation must reflect a high level of medical decision-making. Document the status of all current diagnoses that you are treating or that impact your medical decision-making. Indicate each diagnosis and if it is progressing, worsening or unchanged. Avoid words such as stable or within normal limits when reporting critical care. If the patient is stable, reviewers may not consider them critical. Remember, medical necessity needs to be reflected in your documentation for critical care. Ask yourself, why they are critical. What am I doing to actively treat the patient? What other interventions you are considering? When documenting time, you need to state the number of actual minutes you spent providing critical care. This time needs to be devoted to an individual patient, and should support your individual care and treatment of the patient. Standard time statements such as "I spent 45 minutes providing critical care to the patient" are not acceptable if used for every patient that you treat. In addition, the time needs to be specific. "I spent 60 minutes from 10:00 to 1100. Watch for rounding up your time. If you round up for every patient that you provide critical care for during a day, you can end up documenting more time than you actually worked that day. You need to be immediately available in the critical care unit. Phone calls off the unit do not count. Time not directly contributing to the care of the patient does not count. And administrative meetings on the unit or phone calls regarding other patients do not count. If the time is not documented, subsequent hospital care codes will be reported. It is important to keep in mind that critical care can be reported on multiple days, even if the patient's treatment plan has not changed. The patient needs to meet the definition of critical care with high medical decision-making. Critical care codes include code 99291 for the first 30 to 74 minutes of critical care time. Code 99292 is utilized for each additional 30 minutes of critical care. Additional blocks of time in 30-minute increments may be used after the first 74 minutes of critical care. Report code 99292 for each additional 30-minute segment. Services provided on the same day by a physician or other providers in the same group practice will be aggregated. All the visits must still meet the definition of critical care. Certain procedures are included or bundled into your critical care time. These include chest X-ray interpretation, blood gas interpretation, temporary transcutaneous pacing, gastric intubation and pulse oximetry, to name a few. Critical care provided within the global surgical period will not be paid unless it is documented that you provided a significant, separately identifiable E&M service above and beyond the usual pre- or post-operative course. If critical care is documented on the same day as an inpatient or outpatient E&M service furnished earlier in the day, both services can be reported. For example, you see the patient in the morning and complete an H&P on the patient. Later in the day you are called urgently to see the patient as the patient has desaturated and requires immediate intubation and ventilator support. You may document critical care if you spend at least 30 minutes of time with the patient. Let's discuss critical care when working with residents. The same three key elements of critical care documentation apply to teaching physicians: provider time, patient condition, and medical decision-making. All must support critical care guidelines. Your documentation should support that you are actively involved with the patient for all the time you report as critical care. Time spent instructing the residents may not be counted towards your critical care time. Time spent alone by the resident performing critical care services in the absence of the teaching physician cannot be counted toward critical care time. Only time spent performing critical care activities by the resident and the teaching physician together, or the teaching physician alone, can be counted toward critical care time. The teaching physician may refer to the resident's documentation for specific history, physical findings, and medical assessments. However, it cannot support the actual time you spent with the patient. The teaching physician's documentation must include substantive information including: patient meets critical definition. What made the patient critical? Nature of the treatment and management provided by the teaching physician. Time spent with the patient including actual number of minutes spent with the patient. The following would be an acceptable teaching physician critical care progress note. Patient developed hypotension and became hypoxic. I spent 45 minutes while the patient was in this condition providing fluids, pressors, drugs and oxygen. I have reviewed the resident's documentation and I agree with the resident's assessment and plan of care. Note: coders may only use the teaching physician's documentation in support of billing critical care services. Critical care services are an important component for patient care in the hospital. Understanding the documentation requirements for these services is essential to continue to provide quality patient care and be reimbursed for the acute nature of the services you provide. Documentation of the medical necessity for all services is important. However, in critical care, you must focus on the elements of time, criticality, and interventions to fully support the services you report. If you have any further questions, please contact LVPG Compliance Education for more information.